Okay, I am going to start the recording. So welcome to recent updates in the treatment of TGCT. During this webinar, all participants will have their mics and videos muted. There will be a question and answer session at the end for this expert's presentation using the questions submitted through the chat feature. We will also allow patients to come off mute and ask questions if preferred. My name is Sydney Stern, and I am the Director of TGCT Programs at TGCT Support. I will be your moderator for today. I'd like to thank Dr. Gabriel Tinoco for spending his time with us, and thank you all as well. Now I'd like to introduce our speaker today, Dr. Tinoco. He's a medical oncologist who specializes in treating patients diagnosed with bone and soft tissue sarcoma, as well as TGCT. The lack of treatment options in sarcoma and TGCT is what initially inspired him to go into the field because it created an opportunity to develop new diagnostics and therapeutic tools through basic science research and clinical trials. Dr. Tinoco's research focuses primarily on precision oncology and translational-based trials. One of his recent projects also looked into the use of tumor DNA as a diagnostic tool for sarcoma. Additionally, he serves as a clinical associate professor in the Division of Medical Oncology at Ohio State University. Dr. Tinoco, I will let you take it away.
Thank you so much. And let me actually put this in. There you go.
Looks
Everything
good.
looks okay?
Yep.
Oh, awesome. Great. So thank you so much for the kind introduction. And I'm thrilled to be participating in this opportunity. It's great to connect with patients this disease, and kudos to you for all the excellent work that you do for this community. So I'm a medical oncologist and I specialize in sarcoma. Those are my disclosures. And I remember vividly the first time I saw my first TGCT patient. At the time, it was called PDNS, and that was when I was a hematology oncology fellow at the University of Miami. And I was working with Dr. John Trent and Dr. William Wilkie, and they were actually seeing patients in the Pexidartinib trial. And I was shocked, to realize that non-cancer can have such a devastating effects on patients and their quality of life. And looking now on what's happening in the field, I'm happy that things are changing and there's a dynamic, a positive dynamic with drugs recently approved and with future drugs. Hopefully, I will give more options to patients. So this is encouraging and inspiring, and I love the opportunity to share some of the new things in the field. So I'd like to give a little bit of an introduction, a couple of slides, so we can maybe focus on some of the new information trickling down, and then I want to make sure that I have plenty of time for questions. So what is TGCT? So TGCT is a tenosynovial giant cell tumor that is basically a rare neoplasm that arises from the synovium. It can be also tendon sheaths or bursae of the joints. And it is characterized by proliferation, that is continuous growth, or immune cells that look like a little bit of a synovium, and they're big and they're giant. That's why they have the name. And they often lead to joint pain, swelling, restricted movement, and eventually can affect the joints in a bad way. Many joints can be affected. It's just show you the different structures that we just discussed. And there's some differences and similarities with cancers. But just want to emphasize that this is not a cancer. Cancer is a neoplasm that has the ability of metastasize to go and spread. As you know, there is two different types, localized and diffuse. By far, localized is more common, but this is a really rare situation, right? This is a really rare disease. It's calculated that maybe we see around 600 new patients every year in the United States. So in terms of the localized is more common, is usually single nodule in a joint or a tendon sheet. And this forms typically it's slow growing and tends to occur more in the smaller joints and most commonly seen in fingers and hands, and sometimes can be an incidental finding. The diffuse version is less common and affects larger joints. Can be multinodular, meaning there can be multiple nodules at once, and affects mainly or more frequently knees and hips, and definitely is more aggressive. And as you can see, the distribution is there. There's some calculations here, and it can be 39 per million overall, with the diffuse being 4 per million. And sorry, 43 overall, and with a localized nodular 39. I wanted to show this cartoon to visually explain where the systemic therapies work. So the underlying molecular driver of TGCT is the colony stimulating factor 1, or CSF1, which is overexpressed. And this molecule will attract and stimulates the proliferation of this immune cell, mainly macrophages and other inflammatory cells in the synovial tissue. So as you can see here in the cartoon, this represents a tumor cell, and this represents the tumor-associated macrophage, this inflammatory cell. This here as the CSF1, and then this little thing here that looks like an antenna is the receptor. So there is different drugs that will block the effect of the CSF1 at different stages. And here, just showing you some of the drugs there, and then some of the trials that we'll be discussing a little bit. A little bit of some information, general information about clinical trials. So clinical trials is the way that we advance the science in patient care. And then we want to test something like a medical, surgical, or behavioral intervention in people. And we want to determine whether this is safe, effective, or not. So there is different phases in clinical trials. The higher the number, the higher the amount of data. And I think it's important for patients to know. So as you can see, there is the definition. Most commonly, we see phase 1, 2, 3. Phase 4 are not as common, but those phase 4 are trials that are looking at long-term effects and safety. And we're going to be discussing one. So that's why I wanted to introduce these concepts before. So when we say a drug works, what does it mean? So the way we define that is using something called endpoints. Endpoint is something that we can measure, and it's an outcome we can define. We can use to know if the intervention or treatment is beneficial or not. So now let's focusing on the systemic therapies. So this is a list of treatments that we use for TGCT in general. They're FDA approved, they're non-FDA approved, and then those are what we call emerging therapies, that they're clinical studies and some promising drug that is there. There can be a couple of other ones that we'll touch briefly in the future, but this is kind of the overview. So now the new FDA approved drug is Vimseltinib, or Romvimza, that will be expanding on. So looking at these two, let's start with Pexidartinib. So Pexidartinib is the oldest FDA approved drug for this disease. This is a direct CSF1 receptor inhibitor, and it's an oral medication. In this table, we have few highlights that I think is important to discuss, and they're defined as pros and cons, but every drug will have pros and cons. In the case of Pexidartinib, we have data, significant data showing that this is effective, and it can rapidly improve symptoms and can lead to tumor response. We'll touch on this in the next few slides, but this one can induce long-term remissions. And if the FDA approved this drug, with an assistance program, patient assistance program. That's as most of you guys know, is something that we call REMS, and it was basically designed because concerns for liver toxicities and significant risk that most people is aware by now. The REMS programs requires intensive lab monitoring, and that usually more intense at the beginning of treatment. This drug can have off-target side effects that can lead to treatment discontinuation that are not linked to liver toxicity. This drug needs to be administered with a low-fat meal for optimal absorption, and requires that patients take 2 pills every day. And this drug is not approved in Europe. And Pexidartinib was approved by the results of this trial called ENLIVEN, and that is listed here. The response rate was 39%. And RECIST listed there is just a way, it's an acronym that we use to define radiographically, meaning in looking at the imagings, what means something that is responding, what means that something is stable, and what something that means that is not working. So about 39% of patients with this disease had some significant response at 25 weeks. But when we change the way we measure the success, which is by tumor volume score, which is a way to kind of try to understand what's the volume of disease, the response was even higher, 56%. Patients also experienced significant improvements in symptoms and range of motion, and the duration of response was 22, with 22 months of median follow-up was not reached, unfortunately, but still there was patients that had a lot of response, and that was the first drug approved at the time. Before I go to the last point, I'm just gonna point out here what this means. So this is something that we're gonna be familiarized with during this presentation. We're gonna see that a lot of these graphics, and this is a waterfall plot. So what this means is that each little bar you see here is patients, right? Or tumors in individual subjects in the trial. Here, what you can see in the x-axis is the change in the percentage. So anything that goes down means that it's a nice response, that something is good. Something that grows, like these few bars here, is meaning that something is growing. And that means that your medication is not working in those particular cases. So you can see here that in the graphic at A, you can see that it's a really nice, robust response, which is kind of what you aim to see in those, in a positive trial. So going back to this last point here, that some patients who discontinue Pexidartinib after achieving response do not require retreatment for years. And that is based in this recently published study, November 2024. It's a phase 4 trial. And this phase 4 trial was looking at patients that had received Pexidartinib before, either in a phase 1 or phase 3 studies. In this study, the takeaway of this study is that about 21 patients that chose to enter to treatment continuation, meaning, so let's back up a little bit, sorry. So this study basically wanted to see how real life works. So for the patients that received Pexi before, they give them 2 options. So they can continue medication or stop it and kind of see what happens, and potentially you can restart it again. So they saw that about 54.5% of patients that discontinue the Pexidartinib show that there was a progression, there was a regrowth of the tumor at about 22 months, so about 2 years. That also means that about 45% of those patients did not experience that, which I think is very significant, and that's what it means, the previous bullet. Sometimes patients that take these drugs, stays in the drug, stop it, may see a response that lasts a few years. I think it's clear why those differences are. I don't think it's clear if there's joints that are more affected than others, but this is really interesting because, I probably we're gonna see this later in the question session, but one thing that I commonly see from my patients is what can I stop? So this hints a little bit potentially we can happen, and we can discuss a little bit further. But I think this is really relevant with this, and I like to follow the data wherever it leads me, and I think this is promising data for patients. We talked about the side effects before. Some of the more common side effects that we see here is hair color changes, skin color changes. So Pexidartinib is a drug that affects multiple targets, not only CSF1, also affects KIT and FLT3. And KIT also has an effect on melanocytes. So melanocytes are the pigment cells in your body, and that's why this drug has this profile. Some of the newer drugs that we'll be talking later have not really reported these changes in the hair color and so on. And it's because they're more refined to just hit the CSF1 target. We briefly talk about the black box warning, and this is important, and you already know, but I'm gonna go over that briefly. And it's that in these drugs usually not only studied for one disease, for TGCT, they were also studied for other entities, including cancer. So there were in cancer trials, 2 patients developed this liver toxicity. One, fortunately, passed away, and the other one was so sick that they required liver transplant. In the TGCT studies, 3 patients had significant liver inflammation. And for those characteristics, the FDA require like a close monitoring, and that's what our REMS program is. We discussed this before briefly. More common side effects include hair whitening, fatigue, itching, and rash, some GI problems. There is some swelling around the eyes, but it's a little bit less comparison with some of the other drugs. And then the skin rashes can be definitely difficult to manage sometimes. From 2019 to 2023, the way you recommended the Turalio or Pexidartinib was different. And recently, the company showed us some data suggesting that adjusting the dose from 200 to 125 milligrams, but taking it with a specific diet that has 11 to 14 grams of total fat, and may also be effective, and that's a current recommendation in the label. With that, we're going to switch over to Vimseltinib. That's the most recent FDA approved drug, and just happened a few days ago. That's great news for the community because there is more options. As discussed before, there's always pros and cons on any drug you have. And some of the pros is that we know it's effective and it helps improve not only the size of the tumors, but also helps with symptoms. Also potentially can induce long-term remissions. And then in this particular case, we haven't seen any severe liver toxicities in contrast with Pexidartinib. And so far, there is no description of hair depigmentation. And the schedule is a little bit different from Pexi. This one is taken only twice a week, which helps patients to adhere to the treatment. Side effects wise, you see GI, skin rashes, and mainly those 3 things. So this is from the label. So it's approved for the treatment of adult patients with symptomatic TGCT for which surgical resection will potentially cause worsening functional limitation or severe morbidity. As briefly discussed before, recommended dose is 30 milligrams twice weekly. And the idea is to take that with at least 3 days or 72 hours between doses. That's the capsules strengths, because I think it's important for you to know that there is some room for dose adjustments. And the common side effects are listed there. Increase in the liver function test, some of them, some swelling around the eyes, fatigue, rash, and so on. So this is from the data of for the phase 3 or motion trial for Vimseltinib. And we were part of the motion investigators, so we're glad to participate in this trial. And there were a total of 83 patients in the Vimseltinib arm and the 40 patients in the placebo trial, because this was a placebo-controlled trial that allowed patients actually to transfer over to the Vimseltinib arm. So in this phase 3 trial, Vimseltinib achieved an overall response rate of 40% at week 25. And that was done by the measurements that we discussed before, called RECIST. However, we used the tumor volume score that I mentioned for Pexi. The response was a little bit higher, of 67%. There were a lot of improvements when you compare with placebo, but for the patients that were receiving Vimseltinib, he had an improvement of almost 20%, and the group they received Vimseltinib versus placebo for improvement in an active range of motion. Also, there was a significant improvement in physical function, stiffness, quality of life, and pain, as listed here. I know it's a little bit tricky sometimes. The arrows mean improvement and sometimes don't go in the same direction, but it's important to know that overall there was a statistically significant improvement. Regarding safety, I think overall Vimseltinib was well tolerated, with most treatment related adverse effects being grade 1 or grade 2. So the grading is the higher the number, the worse it is. So 1, 2 usually are things that we can control relatively in an easy way, quote unquote. I mean, usually 3 or 4 sometimes requires significant attention, medical attention, sometimes hospitalization. So it's good to know that most of the side effects are relatively not severe. So far, there was no evidence of cholestatic hepatotoxicity or drugs-induced liver injury. And about only 6% of patients that experienced side effects associated with this drug had to stop the trial. So 94% did not. This is some of the side effects that we discussed before. Eye swelling, issues, with fatigue, and skin rashes definitely were present. And then also in the table 4 listed here, you can see some of the liver issues found. So it's very important for us to know that we need to monitor the liver function and all these drugs. And I think it's key for you guys to know that and make sure that that's happening routinely. But overall, the data we see does not suggest the same levels of potential toxicity seen with Pexi in the initial trials. With that, I think we're going to focus now on the emerging therapies. That includes 3 drugs. 2 of them have active clinical trials. The third one is a standby. I haven't heard any updates in some time. So the pimicotinib, or also known as EBSK-021, it's another oral CSF1 receptor inhibitor. There is some phase 1 trial data there that led to a phase 3 trial data called Maneuver. In Maneuver trial, OSU, the Ohio State University, participated in that trial as well. I completed accrual as well. And they have an update that I'm going to touch on in the next slides. But briefly, this was the design of the trial, basically a phase 3 trial with different parts. And also placebo trial. And they also allowed crossover, so patients will be receiving the study drug. So in November, the company released an update saying that they achieved the primary endpoint, which was a response rate at week 25, similarly to what we've seen in Pexidartinib and Vimseltinib trials. And the response rate is listed there to 54%. We haven't seen the full data yet, so I think hopefully later in the year we'll have access to that. But this is overall potential good news for the field to have another successful drug. But more to come, because definitely would like to review the data with detail. This is from the phase 1 trial data. And then the phase 1 trials, which are usually early trials that aim to look for the right dose and to study, how the drug affects your body and how the body is affected by the drug, and collect data, early data on effect of the drug. The phase 1 trial is actually very promising at the time. With, again, this is another of this waterfall plots that we discussed earlier. Each of the bars is a patient, and here is the change in the size of the tumors. So what you want to see in a trial that has a true effect, something that is actually helping shrinking the tumors, you want to see these bars going down, like in this case. And when you see data closer, this shows that there is 68% response with the early trial. So, usually what happens is that as you have more patients enroll in these trials, this response rates tend to go down because there is a dilution of the effect. So what we see often is that early trials, these numbers tend to go down in a phase 3 trial. That happens with the other two drugs that we discussed earlier. In terms of side effects, they're listed here. This is for the phase 1 trial. Again, very similar to some of the things that we discussed before. And what's a monoclonal antibody? And the reason why I'm saying this is because we're going to talk about Emactuzumab next. And that's a little bit of a different drug compared with the other drugs that we discussed before. The other drugs belong to a class called tyrosine kinase inhibitor. This is monoclonal antibody. So a monoclonal antibody, it's a protein that is engineered to bind one specific target or substance. And usually when it binds, it cannot interact with anything else. So what potentially can be the advantages? That is very selective, that potentially if you are just aiming to hit one target, less likely you're gonna hit other targets, and it's gonna give you potentially less side effects. Potentially you can get away with long intervals between doses, because these drugs tend to stay longer in the body compared with the tyrosine kinases. However, like everything else we discussed, there's pros and cons. And so the cons is potentially you can have immune responses, and you require something IV through the vein, and that can be invasive for some patients. And that's why we are going to be focusing in Emactuzumab. So there is currently a phase 3 trial called the Tangent trial that is open at Ohio State University. This trial is looking to IV infusions every 2 weeks, and the idea is to do it times 5. And then you can observe the patients and see how patients do. This phase 3 trial is also a placebo randomized trial. 2-to-1 means that every patient, so there will be more patients in the Emactuzumab trial than the placebo arm. And then 2 patients will have open label and maybe opportunity to cross over. This study is open for patients older than 12 years old, which, we know that there's patients, young patients with TGCT, and this potential can be an option for them, because we don't have significant data in terms of treatment. And private treatments allow, but at least 3 months before they need to be off any treatment for 3 months off. We call that the washout period. And patients that receive previous Pexidartinib, it's okay to participate. This is the phase 1 trial that shows really significant disease in different patients. This is again another waterfall plot that shows again significant shrinkage of the tumors. These bars are going in that direction, and each of these colors represent a different dose. So for the early phase 1 trial, they seem to think is that about 71% of patients had a response. And at 1 year, the response was seen in 70% of the patients. And at year 2, 64 patients still had a response, which is very significant. And I don't think I explained this before, but this is what we call a Tumor's plot. So each dot represents a patient here. And then this, as the time goes by, you can see what happens to each patient. And side effects wise, you see them listed there. Again, a lot of overlapping between side effects because the targets that you're hitting are similar. So there's like drug class side effects, which are basically, swelling around the eyes, fatigue, skin rashes, and some GI side effects. So that's why it's so common. So the other drug that we can touch briefly based on is the AMB05X. That was the injectable drug. Then we have some more information back in 2022. But unfortunately, there was discontinued due to financial issues, and I haven't heard any updates there. There's a couple of other 2 drugs that I haven't really heard anything else, and maybe we can ask Sydney if she has any information on that. They're listed there. And we discussed the 2 drugs with the trial, but the only one with a trial open right now, proven patients, is the Tangent trial. They're listed there in the slide. For the MB0X5, that was injectable, and the patients have significant response in the early trial. Some of the side effects were a little bit less. I think some of the thoughts is because it's in the joint, it's less likely it's going to have systemic effects. So, fortunately, we'd love to see how that develops, but fortunately, I haven't heard anything new. So far, I've given a lot of information, so probably would like to keep it like that for now. And this is a small table that aims to kind of synthesize some of the things that we discussed with the drugs that listed there. Again, some of the side effects listed here for some of the drugs are really unique for some of these, like Pexidartinib. Emactuzumab is a drug that we didn't touch much base on. I have a slide, maybe we can touch on that if we have time, but Gleevec has been around since 1994. It's not exclusively designed for CSF1 receptor inhibition, but is a tyrosine kinase inhibitor that also hit the multiple targets. And we use that in my clinic in sarcoma world for just gastrointestinal stromal tumor, and also in hematology for chronic myeloid leukemia. It's a drug that has very mild toxic profile. I use it quite a lot, and there is some data on TGCT, and actually I have a few patients on it right now because there is a lot of data on toxicity and long-term effect because it's been around for so long. And then that shares some of the side effects with Pexi, and I think especially hair color changes. So this is listed here for you guys to review. And happy to go back on this one, but with that, I want to make sure that we have plenty of time to go over your questions. And I don't know if you want to take on Sydney or
Yep.
to be great. Thank you.
Yeah, thank you so much. That was a lovely overview of the many drugs in a tiny little rare space. We did have some questions submitted. Please, anybody, please feel free to go to the chat feature down at the bottom and add any questions. The first question is someone had borderline high cholesterol and whether cholesterol would be considered in preemptive treatment before going on a drug like Vimseltinib.
Yes, so thank you for that. So some of the side effects we see from these drugs can be affecting the cholesterol. So definitely a possibility for that. So we have to make sure that we control this and monitor the cholesterol as the time goes by. So yes, we have to be careful with that.
But wouldn't need to preemptively treat.
I'm sorry, the what?
But you wouldn't need to preemptively treat, right? If it was borderline high?
No. So you're right. So we have to just monitor it and act accordingly. I think there is no specific numbers that we need to hit before we start the medication. Just watch it, and if it goes up in a significant way, we have to treat it.
Thank you. We have some questions about CSF1. You know how CSF1 plays a big role in the immune system itself. And are there any special concerns for patients, whether they have a reduced immunophenotype, if they're immunocompromised, or whether they should have some specialized care to offset some of those potential side effects?
Yeah, no, that's a good thought. I haven't really seen any data on that yet. I think as the time goes by, we gather more data, we can revisit this. But to my knowledge, there is no specific information on that or things that we should do differently. Um, but that's an interesting thought.
So you would say that patients aren't immunocompromised?
No, I haven't seen that. I haven't seen patients on these medications having more infections or more prone to develop, pneumonias or other type of infections. So I would say no, no information on that, and no data backing special treatment or immunocompromise.
Great. That's a question we get quite a bit. And some people, right? You might as well act like you're going to get sick with the high amounts of flu and colds over the winter, but it's good to know we're not compromised at all by being on these drugs. So we talked about Turalio and Romvimza. For those that don't know, brand names are names that are given for marketing. So Turalio and Pexidartinib are the same. Romvimza and Vimseltinib are the same. But when we talk about those drugs and they have different dosing, one is daily or twice daily, and the other one is twice weekly. Is there something that makes them different as far as like how they work?
That's a great question. So there's differences with Pexi and Vimseltinib. So Vimseltinib is a more specific, better designed to just hit that specific target. And potentially that's why it stays longer in the system. Pexi tends to hit other targets as well. That's why we see some of the side effects we see. So yes, the drugs are different. Vimseltinib is more refined, and more specific version trying to hit that specific target.
Okay. Do you want to describe like the difference between the you know how it's a switch receptor, how it like targets a different place on the receptor, so they're different in how they target it too?
Um, if you have that information, I think that would be great. Yes,
No,
yeah.
that's
So I,
okay.
I
That was
don't
one
have
of
a
the
slide on that, but yeah.
No, that's okay. That was one of the questions given. So Turalio binds directly into the pocket. Almost, we give the analogy all the time of a catcher mitt and a ball. It just binds right directly into the mitt. Whereas Romvimza or Vimseltinib kind of like punches the catcher and it changes the shape, and then it can't catch a ball because it's laying on the floor somewhere. So like we use that analogy. So I was just curious if that has to do with some of the dosing differences even.
I'm not aware, but I'll be happy to look into it and give you an answer. I think that's good to know. And I really like the way you explain it. I think that's great for patients.
The baseball analogy. You can see I have an Orioles shirt on. So we did get some questions related to fertility concerns with any of these drugs and whether there's special considerations for patients who would like to be pregnant and whether you advocate for freezing eggs before kind of the realm of fertility and your advice.
Yeah, so I think that's a question that we discuss often with my patients in the clinic, because it's just reality, and sometimes patients are not considering, having babies, especially women, right there. But things change, life changes, and you need to be ready, and you need to consider some of the options. So reality is that some of these drugs, they're relatively new, and long-term data on fertility is very limited or non-existent. So the answer for that is probably we don't know. There is early animal models that are required to be studied for the approval for some of these drugs. So I will say that it's better to act with caution. And I'm not advocating for everybody to go into egg preservation, but I think it's important discussion, because this can have a impact. Some of the data we've seen doesn't really tell you that it's going to be a long effect. And if you see the packages of Vimseltinib, for example, the recommendation is for women to use anticonceptives, right? And then to try to get pregnant at least a month of stopping Vimseltinib. I think that's the only clear indication there that I've seen. But
And that's based off toxicity, though, that it's like embryo fetotoxic, right? All of
correct.
these drugs, yeah, all TKIs, I feel like.
and they have to be exactly, they have to be studied. That's mainly animal models, but long term we don't know. We have more data, for example, in older drugs like imatinib, right? And sometimes from the safety perspective, some patients decide to go on imatinib, even though that has definitely lower chances of working, but just for that concern of long-term effect that we still need to wait for the data to mature.
And so imatinib doesn't have the same level of concerns.
There is more data, at least. So, I mean, that was approved in 1994, so we have 4 decades worth of information. But this is important discussion. I want to highlight that, like, every time you kind of, start a new medication, especially chemotherapy, just make sure that you talk to your doctor, express your concerns, and see the data. And, we have to take a decision eventually, but I think it's important to discuss.
So, staying on the same mind of kids, are there concerns in younger patients? None of these drugs are approved for the use in patients under the age of 18, but we inevitably have patients in our community that are given it off label. So, are there concerns with growing and growth development with some of these drugs?
That's something that we discussed before, and there's a concern there. I think that's why it's also important to get data. I think the only trial that I'm aware is the Emactuzumab trial that allows younger patients to be part of it. But I think there's concerns that this can affect the growth plate, right? And then can limit the growth of the younger patients. But the issue is that, for example, what you're going to do, right? If you have a patient with severe symptoms, pain, his life is disrupted, and he's young or she's young, and then what are you going to do? So it's a significant problem, and I look forward to see when the data is mature in the Emactuzumab trial, what things would look like. And also, I think
There's also an
this,
NIH. There's an NIH trial that allows Turalio. I assume they'll expand to other drugs as they get approved, but that includes those down to 3, I think is the age.
yeah, exactly. So the other thing is that exactly see what the other PEX data shows and try to come up with a safe way to provide care for those patients that are in need. And there is a lot of questions in that population. So hopefully more data will help us fill those gaps.
Yeah, we can't ever forget about our pediatric patients. So kind of to switch topics down to treatment is we still hear patients treated with radiation. And we, like to ask every single person, someone asked in the chat, their feelings and whether radiation is really useful treatment, and whether it's also kind of off target used in any of the diagnostics.
So this is very controversial, I will say, and I was telling you that I had this discussion with one of my radiation oncologists here, Dr. David Konakowski. He was discussing with me the data that we saw, especially covered from Stanford. So there is data, of course, there is not unlimited data on long-term effects of the joints, and we know that radiation to a joint usually causes significant issues as the time goes by. The good news is that now we have all these medicines, and hopefully we're going to have more options for our patients soon, so we can explore and discuss. I'm saying that, I tend not to recommend radiation as first line or second or third, but I think we need to evaluate each case individually and see what is considerations. But systemic options are very, effective. They're safe. We have, more and more. So I think in my mind, radiation keeps falling down in the list of options.
We like to hear that. I'll say 5th, 6th, like 7th line, never. Thank you. So as well, on the same kind of note of using radiology, so X-rays, do you see a use for X-rays in monitoring the disease at all? And why not?
Yeah, so there is definitely limitations on all the types of imagings. They're good for certain things and they're limited to certain things. So you have to, pick and choose. Radiation, so X-rays, right? They've been around for the longest. And X-rays are good for example, seeing some of the aspects of the bones, but they're limited in terms of the amount of data it can share in terms of looking at soft tissues and some more parts of the bones. So you want to see a fracture, for example, X-ray may be reasonable, but if you want to see the structure of the joint, you need more refined techniques such as CT scans or MRIs. I will say for the day-to-day monitoring of TGCT, I do not use X-rays routinely. I use more CT scans or mainly MRIs.
Yeah, I saw also that all the trials use MRIs. It seems like the most common way to measure the disease at this point.
Yeah, sometimes some patients for different reasons cannot withstand getting an MRI or getting into an MRI machine. So sometimes we have to be resourceful and look into other directions. But I will say by far MRI is the more known and used study. There's also data on less used imaging such as PET-CT scan, right? So the phase one Emactuzumab trial had some data on impact. But yeah, by far I will say MRI is kind of the standard.
So similar on monitoring and how much to monitor. When patients go off these treatments, do you monitor at the same rate? Do you suggest people go off of these drugs and just monitor at all?
That's a great question. I think that I will say that I will imagine there is a difference in pattern of how you practice. Um, and more to come. I will say more data will probably be needed to have a consensus on how to tackle the optimal approach to patients with DCT. I will tell you something, is that the clinical trials are designed to try to use um, the optimal dose to see efficacy, to see a rapid change in the tumor within a limited amount of time, right? Because that's how you do a clinical trial. And then as we start with the highest dose, and then so depending on the side effects and the problems that you can see, you can adjust the dose and goes down, right? In the clinical practice in the real world, depending on the situation, if you need like a rapid response, sometimes I will imagine you can use a higher dose and then slowly go down. But I will say that for patients in the community outside in the real world, when more drugs will be approved, it will not surprise me. We start low and it slowly will make way up depending on the situation. And also depending on the situation, kind of stop the drug, monitor patients. You can see depending on the severity of the symptoms, the risk of joint damage that can be lost forever. So you have to be careful. You can do scans between 8 to 12 weeks. Usually that's the average, but I think it depends on the situation as well. Or for example, a patient that wants to have kids and want to be pregnant, right? Want to stop the medication. How you monitor, how you do that? That's a lot of questions in the air. I think the practice will help us to understand what will be the best way to do it. In my mind, um, least is best. So if you need the least amount of drug to control and seize or shrink it and make things better, I think that's the way to go, because also will lead to less side effects. But more to come on the time goes by, I would say.
You answered two questions at once. I was going to ask next about going low and slow and then raising, because all these drugs they're approved at the top dose and you modify down based off side effects. But some providers will start at low and go up over time based off of how people are feeling. And so I was curious on what role does the titrating up play versus the high dose modifying down.
Yeah, I think it depends. For example, if you have severe symptoms or you are a really high risk of losing your joint, right? So you need to hit the disease hard. I will probably go for the higher dose possible. But if you don't, and you have some, moderate symptoms, and potentially you have time, you're not gonna lose your joint, then I'm more inclined to potentially cause less disruption with side effects using lower doses of drugs. But again, you know, we'll follow the data. And I think we probably need also to talk more in the community, talk with the other physicians involved, just to generate consensus and approaches. But I think it's just an ongoing discussion with patients, and it's going to be case by case for them.
I also had a question about the different now we have two indications. And so for patients, indication is like the name of the statement at the top of the label that says who the drug is for. And so Turalio has symptomatic patients not amenable to surgery. And Romvimza is symptomatic patients or adult patients with, I think it's like limited function or functional limitations and morbidity caused by surgery or where surgery will cause a limitation in function or morbidity. Do you see those differences in indication? And this is obviously my question, as a issue going forward that providers would have to say patients aren't amenable in order to get treatment in this regard?
Yeah, no, I think, it's a great question, and I think that you're spot on, because, the insurance have to approve, the drugs, and I don't know exactly actually how much this is, but I'm pretty sure it's gonna be really expensive a month. So, we need to discuss the criteria for it to be approved by the insurance company, but also, does it meet criteria or not, right? I think it's key to really have that differences in mind and clearly know what is, the indications and so on. But also, I want to say that there's a lot of remaining questions in terms of what would be the optimal way to use these drugs in relationship with the surgery, right? Before, after, and also that goes to the indication. So I think potentially we can have more wiggle room with vimseltinib, I guess, but those questions remain unanswered, and I hope that we can do a trial on this in the future, in the near future, to get more data. But yeah, it's very, very interesting how to approach the approval and the label and how to go about indication. I think that's key.
Oh, I always thought if you had to rely on a provider, especially a orthopedic surgeon, to tell you they can't remove something, you're never getting a drug. That's my own opinion, so that's why I was curious if that'll play a role.
I usually, I see your point. But also I think that, at least in academic institutions like this, we have sarcoma, tumor, where we have a really dynamic group. We like to discuss all our patients with orthopedic surgeons and with our medical oncologists at large. And we try to get an answer like right away, like functionality and what are the risks of losing the function, risk for the patients, and so on and so forth. I think in the community sometimes we tend to see a little bit of a difference that they don't have the ability of having these tumor boards with um, physicians and nurses and teams that exposed to these rare diseases. But we know kind of what happened with those patients that get multiple surgeries and these things can keep coming back, and you have severe problems in the joints. So sometimes that structure is not available for those physicians in the community. So maybe opening options for them, saying, "Hey, listen, we're here. We have to work with you. I think it's important so patients can have better outcomes." But I think it's our ongoing work. I think we need to keep making people aware, especially physicians, orthopedic surgeons in the community, medical oncologists in the community, that this entity is happening, and we have now medications, and we'll be happy to help them because you see often what happens. Patients have multiple surgeries. They don't even know. They even thought that that's going to be a possibility. And by the time we see them, they're in bad shape. So catching them early is key.
Yeah, we appreciate that. And another plug for going to multidisciplinary sarcoma centers like OSU and some of the other ones on our specialist list, where you just have more options. It's not even about picking going on a drug, not going on a drug, but having the option is requires you to be somewhere multidisciplinary. So just a plug for these amazing institutions as well.
Thank you. I think there is definitely better outcomes for patients with sarcomas and TGCT when they come to academic centers. But I think it's also key for us, for our mission, to spread the word, to help people in the community to learn about these rare entities and to build bridges. I think we need to cooperate with everybody, and we're here to help. And my colleagues in the sarcoma world and TGCT world, they'll also be happy to help.
Yeah, it is a very close-knit community. So switching gears, we know that DSI for Turalio has this patient assistance program. Have you heard anything about a patient assistance program for Romvimza? You mentioned it's probably going to be expensive, which I I assume as well.
Yeah, I haven't heard anything yet. I think probably more to come. The approval just happened the past few weeks. I actually don't know if you have any information on that. Probably you do. But I haven't heard anything yet. Usually, patients that are enrolled in these clinical trials, they will stay on the trial until they have the commercially available drug. I would imagine that now there are discussions taking place between the pharmaceutical company and the insurance companies, and then hopefully we'll kind of provide a kind of a clear path of transition with patients from the clinical trial to the commercially available form, and also how the commercial form will be available, because these drugs needs to be in formulary, and I think they're in the process. But more to come. They're really, the SAFRA, the comparing company with Vimseltinib, they're really active, And I think it's probably a matter of time. I'm sure very soon we'll hear from them.
Yeah, I'm sure you'll even get patients in the upcoming weeks. Just for awareness purposes, there is Access Point, which is their vendor for a patient assistance program. And so I think they do intend to have a patient assistance program that will cover the time between the negotiation of insurance. And then it'll determine based off insurance coverage whether someone will remain on that access program, with some caveats related to, I assume, income and Medicare coverage. But just for awareness that access point is what they're using, and hopefully patients will, that'll help people get on it that want to be on it at a timely manner.
Great. And also they're really, they're really responsive. So, if you have questions, concerns, I'm pretty sure they will reply to us, give us all the information we need. But thanks, I think it's important for patients.
Uh, so another question someone said is, my doctor wants to do a TKR. They've not mentioned drugs. Would you still use a drug? Are TKIs or total knee replacements, are replacements useful? And would you still go on a drug after a replacement?
That's a good question. We see that, situations often when patients ask us, is, I foresee these DKRs to go, less and less potentially as we tend to use more of these drugs. Because we engage with this earlier. And I think that's another question that I want to make sure I plug into. Somebody was asking, hey, if I have limited symptoms, but I see there's growth, should I be in a medication or not? And I think this is important because even if you may not have symptoms, you may lose your joint. And sometimes considering that as a treatment and the need of treatment early, I think can be important too. But there is a lot of things to consider. Um, I I want to say that the earlier we engage with those patients, probably the better. And I, we'll have more data as the time goes by, of course, but is to have options sooner than later. And also, sorry, I see another question in the chat. I want to make sure that I answer that question. He says, any idea of pimicotinib will be FDA approved? And I will say, I don't have yet any information on that. More to come, but I think we have to see probably the full data reported and then they apply. So probably maybe 1 or 2 years. Yeah.
And you said that for pimicotinib. I don't actually have that question. So,
Oh, it's in the chat box. I want to make sure that I answer.
but you said pimicotinib, right?
Yeah, pimicotinib.
Okay.
That's the one that we got the update in November, and we haven't seen the full results yet. Maybe later in the year in ASCO and CTAS, which are the two meetings that we have updates on.
Well, thank you very much. I want to be respectful of your time, and we could go forever, as you could see. So we'll definitely have follow-up with you and other providers within the community. So March 21st at noon Eastern Standard Time, we will also have a roundtable discussion purely for questions to talk about how patients are going to navigate this changing area, as well as 2 drugs approved and potentially the first drug approval in Europe. So please join Dr. Bill Tapp and Richard Rydell in that webinar, and you can find it on the TGCT support website. And thank you so much, Dr. Tinoco, for all of your time.
Oh no, I'm thrilled with the opportunity. I'm very thankful to be able to connect with you all. Want to tell you that we're here to help, and exciting. That it's very exciting that we have maybe more options for patients and hopefully more to come. Look forward to talk to you more in the future. Feel free to reach out. You have my information. Anyways, happy to help.
Yeah, I can't recommend your site enough. Obviously, you can tell, but I will always send you patients, so or recommend you for anybody. So thank you so much.
Very kind. Thank you so much.
Bye, everyone.